Hi. In this short video, I just want to take a couple of minutes to reflect upon some linguistic phenomena that we've seen arise via social media and in mainstream, both commercial and governmental media over the past year and a half since the world went into pandemic. We've seen a lot of talk about epidemiology and it seemed like a meme I saw before I quit social media in late 2019 was like 5 weeks ago, all of my friends were amateur experts or experts in constitutional law, and now everybody's an amateur in epidemiology. And I wanted to just look at some language or some issues that have been uh, regularly discussed in popular culture and assess them on some more scientific or statistical measures to show that to engage in discussion of complex, nuanced issues such as the pandemic and the various economic, scientific, social, political ramifications of that pandemic without due diligence and concern for, well, facts and even competent debate or alternative perspective on things is probably not the best course for scale. You know, at an individual level, if one holds a belief, well, then that's limited, that's isolated. But if people at scale hold false or inaccurate or unreliable beliefs, well, then we start having degeneration of our collective consciousness or our social function, which has knock on effects in other aspects of our life and could carry over into future generations, even. So let's begin with hashtag flatten the curve, which took over social media and late night comedy news back in March, roughly, of 2020, when people started to realize, rightfully, that wearing a mask and washing hands and staying a reasonable distance from others, i.e., not crowding into bars and restaurants shoulder to shoulder, sweating, coughing, sneezing, rubbing, breathing, shouting, spitting on each other, that's reasonable. That people should take these basic precautionary measures, which folks in rural areas had largely known for years. So this was a more of an urban phenomena, we should say, urban phenomenon, that flattening the curve really took over social media. And everybody who is anybody knew that they should hashtag flatten the curve, when a lot of them, I think, didn't really know what that meant. When COVID first took off, hospitals, especially where there was no public health option, were near at capacity. And their objectives were to turn a profit, which means, like hotels, they wanted to keep as many beds filled as possible, so they would reduce the number of beds. And so when they got a spike in cases around the beginning of the pandemic, well, they were overburdened. They had only so many extra beds and so many extra ventilators, and not anticipating this pandemic led to the health systems being under an extreme amount of stress, and we saw shortages in equipment and personnel working on very low sleep, and even room in morgues and in funeral parlors was at a premium, and bodies were stored in unconventional places as the tragedy of the pandemic unfolded. And so one of the first interventions was measures which were intended to so quote unquote flatten the curve, which did not mean that the total number of infections was lower. It meant that by implementing closure of certain businesses and restrictions on certain personal liberties, that the spread of the virus could be slowed such that the hospital and healthcare system weren't so overwhelmed, and that intervention was not intended to reduce the overall volume of cases. If we took an integral of the curve without intervention, it would be the same area, the number of cases, the integral, the volume, the area under the curve, without intervention would be the same as the area under the curve with the intervention intended to flatten the curve. And of course, as time went on and finally vaccines came about, perhaps the number of cases overall are now decreasing. But for those months, all of 2020, when there was no vaccine, the number of cases theoretically was not really reduced. It was just the pressure on the healthcare system was reduced by implementing measures to slow the spread. So it didn't mean that 500,000 people weren't going to die just because they flattened the curve. And in fact, nobody will know what would have happened had they not implemented economic measures, because we don't have any jurisdiction available where the spillover effects from globalized shutdowns did not significantly impact local economies. And so whilst we can certainly guess, and it's probably a very good guess, that the total number of deaths into the future, especially since we have vaccines now, it will be lower. We can't say with any accuracy that the overall effects, certainly not the economic effects, would have been less had they not implemented those controls to flatten the curve. But it's very important to understand that flattening the curve was never to reduce the overall total number of cases. It was just to slow the rate at which infection was spreading. And that is a statistical difference. It's a technical definition that's very important that a lot of people missed. Next up, let's have a look at the idea that people are en masse, quote, risking their lives, end quote, by going to work, be they teachers or healthcare personnel. And I'll put an asterisk by healthcare personnel because being so close to all the infected cases certainly puts their health at a much greater risk than, say, waitresses and bartenders and shop clerks and things. But there has been this idea that anybody who went to work, who was not at home during the entirety of the pandemic, through most of 2020 and still into 2021, was somehow risking their lives just by being outside, just by working in a factory, just by driving a taxi, just by, if teachers had even the option to go to work in schools with students in September, October of 2020, which I probably would have, because in-person teaching is much more favorable, much more beneficial for the students, and much more pleasurable, in my opinion, compared to online teaching. But teachers such as myself would have been considered as people risking their lives. But is that really the case? Well, first of all, it's important to understand that not every case of COVID resulted in death. So no, just on the face of it, nobody's risking their life, because to say that you're risking your life is to say that there is a considerably high probability that you will die if you get COVID. And then there's a considerably high probability that you'll get COVID, and that if you do, you are most likely going to die, or there's a great chance that you're going to die. And the numbers just don't add up in that direction. The infection rate is not terribly high. No, of course, millions of people have been infected, and the COVID virus is a tragedy. Absolutely. However, to say that there's a very high probability of infection and therefore death is just wrong. The United States has far and away the most cases in the world, and we're looking at less than 10% of the population, which is a huge number, and we should not make light of the number. Less than 10% of the population has been infected, and of those infected, and those are the symptomatic detected cases, and studies might suggest that as many as 90% of cases have gone undetected because there are so many asymptomatic cases which are not tested, which would put the infection rate would put the infection rate higher, but it would put the mortality rate at a much lower percent. Compared to other communicable disease, this ranks as the worst in a long time. There's no arguing that. It was number 3 or 4 worldwide for causes of death in 2020. It surpassed all of the other infectious diseases by far, second only to cardiac and cancer-related diseases. Terrible tragedy, no arguing that. That said, with a 1%, 1.8%, or roughly 2%, or less than 2% mortality rate worldwide, this is not the killer that if you get it, you should be afraid for your life. Even just on the face, if we said that all groups within the population had an equal chance of death, which they don't, we'll get to that in a moment, but even if they did, a 2% chance of death is not terribly high. It would be very scary. 1 in 50 death rate is high, absolutely. But it's not as if because there is a 10% infection rate and a 2% fatality rate among that 10%, that anybody out in public doing anything, masked or not, taking precautions or not, is somehow, quote, risking their life. Now, do we need essential workers? Absolutely. I'm very happy that we could still go to the grocery store and that there were people there. Absolutely. I think a lot of people would like that restaurants would have been open the whole time and that people would have had the choice to take their chances or not. But to say that they are risking their lives, as a teacher, I don't think that it would be fair to say that I would be risking my life to go to a school with full classrooms. The numbers just don't add up for me. And so we've got a certain susceptibility. Certain people are likely to get the disease, and then certain people are likely to show symptoms, to be infected, and then certain people are likely to die or recover, and more than 98% are recovering. So the recovery rate's really very high. So you might want to reword your statement and say he's risking his health or she's risking her health by going to work. But even that is not always true because we have other factors. Driving to work, we risk car accident, or people take risks of getting influenza or pneumonia or other communicable diseases which can result in their death. People have, historically at least in factory settings, have a greater risk of getting cancer. Certainly coal miners had a greater risk of getting black lung and dying from work-related injuries or conditions than the average person would with COVID. So to be uncareful is perhaps the greatest problem at all when assessing a very serious issue that we have experts to assess, yet because this politician or that likes or doesn't like this idea or that, then people don't or do listen to and respect that idea. And that works on many sides. And obviously, wearing a mask, staying a little bit further away, avoiding big crowds, and washing your hands, very important. And to suggest that these are just mere suggestions that may or may not have any effect, or that it's not important, is absurd. But equally or similarly absurd is the idea that there's a population level risk for all people, or that the risk is evenly distributed across the population, when it simply isn't. The numbers don't add up, don't pan out that way. And as data continue to come in into the future, we'll understand more about this disease and more about who was in particular, who was particularly vulnerable. Older people, obviously, you can see that the risk of death goes up exponentially as a person gets older. And of course, a person can't get younger by choice, right? But there are other factors than a number which influence their susceptibility to extremely adverse reactions to this disease. Immune system function, and then, as we'll get into in a moment, comorbidities. So given this base case, age 5 to 17, these are children. They're usually healthy, right? Their immune systems are resilient. Other diseases might have more adverse effects on the young. This one does not. These people are the base case. Younger than them, they get infected slightly less. They go to the hospital and die slightly more, or twice as much, slightly more. Cases are slightly more common among all people, evenly distributed across age groups older than that base case, but hospitalizations and deaths increase exponentially. What does that mean and why? Well, we can assume that health declines generally with age, immune system function. People have more negative or harmful habits, years of overeating, of smoking, of drinking, of lack of exercise, have compound effects over years, which manifest into extremely vulnerable states, especially in old age. And then there are factors beyond control. To no fault of their own, people may develop any one of these underlying conditions. It's no secret or no mystery that dementia and Alzheimer's are the most common comorbidities in Canada, when the risk for death is greatest among people who are most likely to have dementia and Alzheimer's. Most people who are most likely susceptible to adverse reactions due to pneumonia. Now, of course, for other categories of comorbidities like hypertension, heart disease, renal failure, diabetes, those risks are distributed slightly more evenly across the age spectrum, generally 40 years and older. We're looking at people whose sedentary lifestyles or genes or environment or a number of other factors have led to their having one or more underlying conditions. But that is the real story of COVID, as it is the real story of most viral infections leading to death and serious complications, that there are more than one or more underlying conditions for 70 to 95% of the deaths. So that, in a nutshell, is the real risk, right? Not just COVID and not just any one of these diseases, but the combination of the two together are extremely harmful. And so what can we do about that? Well, we can try, as scientists have been saying, as doctors have been saying for forever, really, try to reduce our risk. For example, obesity. Patients who are obese had more complications, had a harder time getting rid of COVID, had more adverse responses to COVID, and these are preventable in most cases. Now, some people are born diabetic, others have thyroid disorders or other metabolic deficiencies that lead to obesity regardless of diet. But obesity is uncoincidentally associated with higher income and therefore largely preventable because it is a voluntary decision, whether conscious, subconscious, or unconscious, to engage in this type of sedentary lifestyle, eating certain foods that are well known to be of little to no nutritional value. So while the world's economies have largely shut down and people are going bankrupt and the knock-on long-term effects are unknown, while in the United States and Western Europe and Canada, people can still subside on unemployment insurance checks, the same is not true worldwide. And the effects of the economic shutdown are far greater than even they've seen in the US and Western Europe, where perhaps financial systems are so powerful that to be bankrupt, to miss a rent check, to miss payments on utilities is of greater consequence than it is worldwide. It's no coincidence that countries with lower rates of obesity, like Thailand, had lower mortality rates, like Vietnam had lower mortality rates than those in the US. And these are countries where healthcare is not known to be of as high quality as you might see in the United Kingdom or Canada, right? But there are more underlying comorbidities we can infer due to general population trends, which show that roughly 1 in 3 Americans and similar numbers in other Western wealthier countries are obese. Diabetes being on the rise. It then is a public health issue, and has always been a public health concern, that people are not paying attention to preventing weight gain. They're not paying attention to physical activity and eating habits. And one could then argue, well, if this is just the first in a string of pandemics, and we've seen trillions upon trillions of dollars in lost value, not just from stock markets, because stock markets are at the highest they've ever been. There was this discussion that there was somehow people were suggesting trading lives for stock market gains back in 2020, but such was just not the case because stocks continued to climb as real people who worked in service industries who could not just take off and work from home remotely, they went bankrupt. So, and the number of lives lost, while not negligible, certainly was not near the rate which one could infer people were saying would have been sacrificed had there not been such draconian or extreme measures in that intervention to, quote, flatten the curve, which perhaps a lot of people didn't really understand. So I think it's reasonable to argue that if the population and if governments and if all these interested stakeholders truly want to protect the herd from this, well, it's probably too late for this one, but from future pandemics, then the best course of action would be prevention. And prevention is not wearing a mask in perpetuity. Prevention is not closing our national borders in perpetuity and requiring invasive medical checks to cross borders and some sort of virus passport system or inoculation passport system, which would possibly violate privacy rights of patients. The real solution lies in the type of prevention that people 100 years ago knew about implicitly, don't drink so many sugar pops, and don't eat candy and eat ice cream all day, and reduce certain types of calories to a reasonable level that a doctor might recommend. Or for governments, tax sugar drinks more, tax fast foods more, put those excise taxes or those sin taxes on things that are inherently destructive to the community, which affect productivity and affect the public health, especially if we are going to pursue a public health system on the government or on public finance. Because if the public is footing the bill for healthcare, then it stands to reason that there's a national interest in preventing diseases such as obesity and hypertension and diabetes, which would cost the health system billions, if not trillions of dollars. And even if we're not pursuing a public option in healthcare, then it stands to reason there's an overwhelming public interest to prevent these diseases, to avoid another pandemic, the likes of which we've seen in 2020 and 2021, the effects of which could extend for a decade or longer. So, what this entails is that when people talk about obesity, we don't infer morality, but rather just something more related to science and health. And that people refrain, exercise a little bit of thoughtlessness or mindfulness, I suppose we could say, in not making an immediate objection to an accusation or a label or something like that regarding obesity or health, but that we rely on standards which are objective and which have valid data to support them. So it would include being a little bit more open-minded about discussion without becoming shrouded in the type of hypersensitivity or defensiveness that we might often see where people would just launch claims of fat shaming or something like that, when in fact I don't think that there's a moral implication, i.e., there's no shame in being fat. It's just that it poses a risk to oneself. And when we take aggregate numbers of people who are obese, then it poses a real risk to populations and national economies. And so there's a public interest as well as a private interest in attempting to control that situation. But again, by the numbers and within the realm of science, these are not wild ideas. It's just on social media and in popular culture where linguistic phenomena arise and words take on such a level of imprecision so as to nearly remove the actual semantic or default definition of words, then we get these abnormalities in our communicative systems that affect our ability to effectively communicate facts and to even agree that there is an objective fact. And this goes on the right, left, center, and all around the political spectrum. So next time you go and say that you want to flatten the curve or that somebody's risking their life, well, maybe they're risking their life for that McDonald's, and maybe we should defund McDonald's. Or maybe they're risking their life for that Budweiser. Or maybe they're risking their life for that next pack of cigarettes. Or maybe they're risking their life driving fast. Or maybe they're risking their life at work, certainly, maybe. But there is probably a lot more to that situation. And perhaps that individual is risking his or her life going to the hospital, working in the ICU with COVID patients. Sure, we can agree on that. But then again, maybe it's just risking health. That inference is not scalable, right? So it's important that we don't project our own vulnerabilities onto the population, i.e., or in other words, if we are experiencing one of these comorbidities and we are particularly susceptible to adverse reactions to COVID, then we don't act as if everybody faces that same level of risk, because that's just not so. Conversely, if we don't have any of these comorbidities and we're perfectly healthy, normal BMI and active and eating well and just loving life in lockdown as much as we can, then we don't project that low level of risk onto the population, but that we would take a more nuanced and individualist view or case-by-case view, and then take the sum of all these different cases and groups to come up with a population level assessment. Right? It's really important that we don't overgeneralize and become imprecise in our language and in our thinking, such that we communicate a clear bias and that we ignore facts in favor of something that just confirms what we believe or what we feel. Right? So have a quick look around the internet if you like. Comment if you like. But again, please be precise. Thank you.